Hi, I'm Dr. Michael Janssen. I'm a spine surgeon at the Center for Spine and Orthopedics in Denver, Colorado. Have been a spine surgeon here in the Denver geographic area for about 25 years. And this afternoon I wanted to cover one of the most exciting topics is degenerative disc disease. People hear this term all the time and they're trying to figure out how it affects them. And what does degenerative disc disease mean? And is it really a disease or is it just a normal aging process? And to some extent, where is the pain coming from? I hope that this presentation raises more questions and sometimes it answers, but it gives an oversight of the kind of dilemmas that I think about every day when I'm evaluating patients at the Center for Spine and Orthopedics and trying to help the patient understand, as well as their primary care physicians, physical therapists, chiropractors, family members, on really what patients may be suffering from and maybe to some extent what we can or can't do about that. So the key today is degenerative disc disease. Where is the pain coming from? What is the cause of the pain? And is it really a disease or is it just a normal aging process? This cascade you see on the left is a series of cadaveric photographs to some extent from spines that look at changes in the disc. The top picture is what a normal healthy disc looks like, typically in someone in their teens, maybe, and then the very bottom disc is something that looks completely worn out, like a tire driving on the rim, on a patient who may be 70, 80, 90 years of age, and then all the other types of issues that we see in between of different types of discs. Some of these cause pain. Some of these remain asymptomatic. And so each of these can affect humans in a different capacity. So where's the key is that we know about how this occurs. Just like we can look at a patient and look at their skin and say, that person's probably 25 or that person's about 80. We can look at an MRI scan and see some of these discs, and we have a different idea of the age, the mechanical loads, the process, whether it's degenerative or not. And one of the key factors to remember is the disc itself loses the majority of its blood supply by the second or third decade in life. And what happens through this cascade is, number one, there's a loss of cells. Then there's a loss of water. And there's a loss of the proteoglycans that occur where there's a change in the type 2 collagen, a higher incidence of the type 1 collagen. You get tears, or we call that fissures. I tell patients fissures are like seeing the outsides or the cracks around a radial tire on a car. That gives some mechanical changes, and then sometimes we get bony changes, which is this entire cascade. But the reality is when I see patients with degenerative disc disease, we're trying to balance four things: the pathology, the physical exam in the patient, where their symptoms are, and the diagnostics. That means the MRI scans, discograms, x-rays. They don't all fit together perfectly in a puzzle. We wish they did, but we're all humans and everything doesn't quite match. That's why the talent of your clinician and the surgeon makes incredible judgment on picking the right patient at the right phase. Now we can see different patterns, and this is a series of 4 MRIs across the bottom of this screen, and these MRIs demonstrate some changes in the disc and some pooling, which may be some of the mechanical changes we can see over time as it picks up, and sometimes you get altered structure and altered function when that occurs. And this one is a little different where there's no real diffuse visualization, but you get damaged structures. And sometimes then you get some altered function mechanically. Again, it's like a tire on a car, and the sidewall of the tire isn't sufficient to support the loads applied to it. Now some of this is this complex mechanisms of changes in the nucleus and changes in the DNA, and maybe some changes overall in the structural aspect in an environment that doesn't have many cells in it. So the disc itself is relatively low cellular content, low oxygen content, very minimal vascular supply, makes it a very toxic environment for cells to live. That's why I'm not a big fan, at least in 2016, to think that doing stem cell injections in the discs are going to make much of a change in our lifetime, because it's a very toxic area that's very acellular in the first place, and that's why many times these things don't tend to get better over time. Now we try a variety of conservative treatment in patients. We try rest, modification, weight loss, physical therapy, medications, but the key is not all same physical therapy works for every patient. Some patients, no matter how much therapy they go to, it's the wrong therapy for the wrong patient at the wrong phase of their overall disease. Now, we also think that this is the way we look. And there's a famous movie actor, and he probably had very strong discs and things. And over time, though, things change. And our bodies change. Our core strength changes. The discs change. Mechanics change. And that's when the patients start having more and more symptomatology. So as a clinician, I think you have to evaluate the history. You have to evaluate the physical exam in those patients suffering from degenerative changes or lifestyle changes. Sometimes we look at static x-rays, dynamic x-rays, discograms are called provocative tests. Sometimes we give our best experience based upon practicing for many, many years, saying this we think the patient's suffering from. One of the keys I ask the patient is this an annoyance or is this an impairment? If it's an annoyance, I try to get them to live with it and find ways to manage it. If it's an impairment, we try to find ways for the patient to improve. I tend to tell them they typically have three options. They can live with it, they can treat the symptoms, or they can treat the problem. And we'll talk a little bit more about that. Now, is it coming from the facet or is it coming from the disc? Sometimes it's not clearly defined. There's a constant change in the philosophy of the management of degenerative disc disease, and not always can we take a patient like this and look at that MRI and point to say, this is exactly the cause of my pain. This is where the pain is referred from. Sometimes it's a little more complex, but it's not, all the patients don't come with pain listed right over their back like this. I try to assess their pain, their motion, their function, how much it bothers them, whether they've missed much work, how much medication they're taking. We do all these indexes to try to figure out what's going on with the patient in the best. But sometimes their physical exam is somewhat unimpressive. Whether the patient's anorexic or morbidly obese or somewhere in between. In Colorado, we have a high percentage of patients that want to ski, mountain bike, will climb, and when they have severe back pain, it alters their life. Different areas of the United States, we have different patients that have different expectations on when it bothers them. But what do we do with these patients? Do we take patients like this that have these degenerative changes and tell them to live with it? Just tell them to go away? Do we tell patients that they need a fusion or a disc replacement or injections or medications or to go to the therapy for a while? Or a combination of all of these, because every patient's a little different. And so we have to manage these patients to figure out what's the best option for them as we go forward. Now, sometimes all we need is a patient that has a decompression. And this x-ray right here shows a patient with a twisted spine called degenerative scoliosis. I put an illustration there where you can see the black line demonstrating how the nerve is substantially compressed. And sometimes all they need sometimes is to remove the pressure from the nerve. Sometimes we see patients like this. One vertebrae is essentially unstable in relationship to the sacrum. This is called spondylolisthesis. 40-year-old physician, 2 years of severe back pain, 2 years or 6 months of severe leg pain, and basically the L5 vertebrae is not associated by bone to stabilize it to the sacrum. And so in these cases, we do a complex surgery to put screws and rods in the spine, realign the spine, and stabilize it together and give it stability so the patient can move on with the rest of their life. Some patients like this need stability because they have instability, and that's clearly the treatment of choice compared to some of the other technology. Here's another classic example of a patient that has a fracture through the back of the spine. The L4 vertebrae is not associated with the L5. There's darkening of both of the discs, and that's called symptomatic instability. And in both of these cases, the patient needs a fusion. They have instability, they need stability to move on with their life. Because no matter how much they work on their core strength and their secondary stabilizers, they will never stabilize that segment to really meet their overall functional needs. Some patients have deformity. This patient came into our office with a cervical deformity where you can see the neck is completely angulated and she has to tape her head into a wheelchair. And so these types of things need aggressive treatment to place multiple biomechanical constructs into the spine to try to stabilize their head in relationship to their torso to give them a good functional improvement. But these types of things, when we manage decisions in patients and give them a surgical procedure, they change their life. You have a patient like this with a degenerative scoliosis and a twisted spine. It's like driving your car on the rim. The front end out of alignment and it's on the rim. And to do this, it's a major reconstruction. So these are life-changing decisions that it's important that the patients have confidence in the skills, the talents, and the experience of the surgeon to be able to know what's best for them at that phase. For the last 25 years at the Center for Spine and Orthopedics, our surgeons have a lot of experience of spending time with patients like this to help them identify with the patient and their family the best treatment at the right phase of the disease for the individual patient. This patient needed a fusion, needed a realignment. But this changed the patient's life, and we also helped educate this patient what was going to happen if they didn't have any treatment, called the natural history of the disease. Some patients need major reconstructions like this to balance out their spine. It's because their spine wore out. They may have a body and a mental capacity or a mental at 40 years of age, but their spine appears and behaves as someone 70 or 80. So sometimes we have to do major reconstructions like this and have the experience to do that to really benefit the patient from a clinical standpoint. But what we do know is when a patient has a fusion, here's an example of a worn out disc on a cadaver spine, and you can see at the L5-S1 level, the disc above looks normal. You can open that space up, put screws in, create an environment for it to heal together called a fusion. But what we do know is it locks it in place forever. And today, in 2016, we have a lot of experience, about 10 years so right now at the Center for Spine and Orthopedics of doing disc replacement surgery for this compared to that of a fusion. And that sometimes may have a faster recovery, a less downtime for the patient, but you have to pick the right patient at the right phase of the disease. Those patients with instability that we've been talking about would not be a good candidate for this type of technology. But with disc replacement surgery like this, which is all done through the abdomen, allows us to remove the disc, take the disease segment, and put something in that allows it to continue to move. There's a variety of different options. Some of them we have evaluated with FDA clinical trials. Some of them have been removed from the market. Some of them may have just been a good idea, but they allow us to make decisions on what's right for the patient. Not all surgeons have experience in this technology. And so I can go to a meeting and surgeons that only know how to do fusions and decompressions will argue with me that they think these items on the right side are clearly much better than on the left. And as a patient and an informed consumer today, I think it's your importance to have you and your family member make sure that you seek out surgeons that have a lot of experience in technologies and not only in one particular technology, that they do all the same surgery for the patients regardless of what's wrong. Because I don't think disc replacements like this is a new product. It's not like a new car. It's a whole philosophy of how we treat disease, specifically degenerative disease. It allows the spine to continue to move and allows it to maintain its movement, which may be a different way to treat the disease than we've done historically with that of a fusion. It's not new. We've been involved in these kind of clinical trials for over 10 years and have done thousands of patients with a lot of these research and development of advanced technology and have a really good understanding of the best technology at the right phase of the disease for patients that are suffering and having substantial impairment in their life, and which of these is the best for them. That's the key, is to make sure that the surgeon that's treating the patient has a vast experience in this technology. He didn't just go to a weekend class and learn how to use it. And at the same time, he understands which of these implants is best for the patient and best for that particular patient to give him the least amount of risk and the best advanced technology. Because some of these all have different mechanics. Each one of these have a little different mechanic and a different axis of rotation, different for each patient in a different phase of the disease. Some of them have different ways to fix this to the spine. As you can see, some of these implants have keels, like the bottom of a sailboat. Some of them have spikes, some of them have hinges, and some of them rely on some of the patient's own internal anatomy to be able to support that. Some are metal on plastic, which is what 90% of total hips and total knees do. Some of them have different mechanics to the bearing surface. Some of them have different attachment devices, but not one is best for all patients, and we've seen some less than ideal good results from all of these types of technology. So one lesson I like to leave with patients is friends don't fuse friends. So as a clinician, I want to find surgeons that have experience in this technology and can clearly have had evaluate what's best for you and what's going to give you the best overall outcome. The patient has to be realistic too. Sometimes the patient has to be realistic that when they come and say, Dr. Janssen, I haven't been able to run for, the last few months, and they may be really challenged with their weight and a variety of other things. They may not have really been running for 10 years. So we have to really put it into perspective as we all age. Is the patient being honest with ourselves? Are we being honest with each other? What do we really want today, and what's going to give us the best functional outcome for the next 5 or 10 years? I think one of the key things for patients that need this technology is they must have a painful anterior accessible disc. That's why we call this a PAAD. We're doing this through the abdomen. We have to make sure that they haven't had complications or multiple other abdominal surgeries through their abdomen that would make it a higher risk to even do this type of technology. So which of these do we pick? Do we take the patient on the left or the patient on the right? Which one is our patient? Which one is ourselves? Which one is the best treatment? And which one does my surgeon have the most amount of experience? Do we do a fusion like on the left, or do we do advanced technology on the right? There's no exact answer. Every patient, I think, has to be treated and to take a look at what's best for them, not just what experience does a surgeon have in their armamentarium, no different than we pick out an automobile as a consumer or any other product that we're trying to pick. Who's the ideal patient for total disc? A painful anterior accessible disc, highly motivated patient, that really genuinely wants to improve, not on substantial amount of narcotics. We can access the spine, and they're at the right phase of their disease. But some patients that come in with a pain diagram like that, where their whole body is in pain or has substantial weight challenges, may not be the ideal patient to put a disc replacement in, and may be better with other modalities. Here's an example. If this patient has an MRI and I put a circle around it showing that this disc looks worn out at L4, L5, if this is a 45-year-old patient with low back pain, not much leg pain, he continues to work, he's miserable, he's married, he's been tried all kinds of things, 9 out of 10 surgeons, I would bet, would probably offer this patient treatment. If you had the same MRI scan, though, on a patient that comes in who's 45 years of age and has 10-year history of pain, back pain, leg pain, lost their job, dog's gone, wife's gone, they're depressed, they're bankrupt, you're their last hope, probably wouldn't help them, because many times the patient has all of those factors. They expect they're going to go away when the surgeon treats that. So we have to treat the patient. I always think we operate on 4 Ps. The pain, the pathology, that's what's wrong, the protoplasm, that's how healthy they are, and the personality. And the surgeons have to really spend a good time trying to make sure they pick the right patient to get the overall best outcome. Because otherwise, the outcome, no matter, isn't going to be ideal if the surgeon uses the wrong technique, whether that's screws, rods, disc replacements, whatever, it's not going to have a good outcome. Here's an example. 56-year-old patient, 6-year history of back pain, totally worn out disc at the bottom, had a disc replacement, lives in Colorado, plays golf all the time, 6 years out, and has done fantastic. This is a good functional outcome to meet the patient's overall functional needs. Here's a patient that was a dentist, 39-year-old, tried everything, steroid injections, physical therapy, and is miserable. 2 bad discs. He sits for his entire career working on patients as a dentist. He's young and he's miserable. Instead of doing a 2-level fusion on a patient like that, which would change the way he sits, we did a disc replacement on this patient, and he's had a great functional outcome for the last 5 years. I think there are better alternatives, and as a patient and as a consumer, it's their responsibility to find the clinicians around the United States that have a lot of experience in this advanced technology that finds the right thing for the patient. There's a patient with 4-level disease. Classically, these patients wouldn't have surgery. There are clinicians that have experience at doing multiple level reconstructions like this. So why do patients come to clinicians or come to places like the Center for Spine and Orthopedics in Denver? They come because of pain, because they're stiff, because it's changed their sex life, sports, workout, medications, inability to return to work, disability. All of those change the way people's lives are, and they look for alternatives to try to help them. One of the biggest differences is when you do a fusion, you hopefully remove the pain generator. You restore the disc space height. You lose motion with that. You lose balance. That means the patient is stuck in that position the rest of their life. And compared to that of a disc replacement, a patient removes the pain generator, restores the disc space height, restores the motion, allows them to continue their balance, and maybe protects the discs above or below. That's the advantage. We have a lot of evidence, and some of it's been well published at 2 years, 4 years, 5 years, and 7 years, looking at the clinical trials. We did an FDA clinical trial on the lumbar disc replacement we were involved with, and there were a lot of outstanding surgeons in North America that were involved in this. And patients were randomized where a percentage of the patients got a disc replacement and the other patients got a fusion. And we looked at all of these measures of outcome, whether the device was successful, the medications they took, the radiographic appearance, the complication rate, and the overall success rate of improving the patients by more than 15 points, I think was substantial with disc replacements compared to what we have done historically with the fusion, with a variety of different technologies in the right phase of their disease. And a reoperation at 2 years after surgery, or 24 months, the reoperations in patients with a fusion was almost twice compared to that of a disc replacement technology, making the overall success rate an improvement to what we have done historically with a fusion. Does not mean that the other patients are a failure. What this means is that this is the percentage of patients that met all the criteria for clinical improvement, 100%. When you ask the patients would they consider having surgery again, the fusion group about 60 to 70%, and the disc replacement patients about 85% would consider having the surgery again. So the overall improvement of patients with disc replacements compared to that of a fusion, look at all these factors, we think is very promising and very exciting. And it's really not a new technology in 2016. It's a 10-year experience technology that we have a lot of experience with and really understand the best overall outcome, and probably a decrease in the adjacent segment disease. We recently published the 7-year improvements in the Journal of Bone and Joint Surgery in cervical arthroplasty in November of 2015. And the overall success is incredibly promising with all of this type of exciting technology. So in summary, arthroplasty allows the patient to find balance, 1 level, 2 level, 3 level, multiple level disease compared to what we've done in a fusion. This is a historic patient that had a fusion, and you can see the screws are broken, the screws are migrated, the fusion hasn't healed, and we didn't have great answers when patients had multiple level disease, but probably some of this newer and advanced technology we might over time. Here's another case. Patient had a 2-level neck fusion 10 years ago. Family member of mine that I treated, and you can see that once they developed adjacent segment disease, that we did a disc replacement at the adjacent segment with a good clinical outcome compared to that of a overall fusion. The recovery, I think the recovery in a patient with a disc replacement is much better and faster, and return to work status and high demand status with a disc replacement compared to that of a fusion, because the fusions can take a long time to recover. So we've moved to an era today of minimally invasive surgery, so we don't do these major dissections of the posterior muscles, which can inhibit patients for quite a while. So in summary, we think that with degenerative disc disease, we have improved outcomes, decreased rehabilitation, and retained motion with arthroplasty. But there's a lot of exciting technology in spine. We need better ways to repair the annulus when patients have an annulus tear, such as a disc herniation. We need ways to maybe do some of this percutaneously. We've tried that in the past by coagulating or burning or heating up the disc, but it was never very promising. We've tried lasers, which have been abandoned for the most part, besides companies that market using the name laser in their name all the time. But beyond that, the laser has very minimal role in spine surgery beyond that of being marketed with companies around the United States using that in their branding. We've tried a variety of different ways. We've had really an advancement of using the microscope in doing outpatient surgery for one of the most common problems, which is spinal stenosis or disc herniations. And I think in the next 10 years, we'll have a way to go in and place a device and reinflate the disc, whether that's a hydrogel or a material that can actually improve the overall. And we'll continue to improve ways to do fusions and screws and rods, disc replacements, picking the right patient. And we've got a lot of advancement recently on osteobiologics, which is a drug that we can place into the spine to enhance and heal at a much faster rate, higher predictability than what we've done before. And all of these, I think, are exciting to help patients that truly need an operation to give them the best functional outcome at the right phase of their overall disease. So how do we treat patients today, and how do experts like myself and my other team members treat family and friends for this? We try not to fuse them. We try to get them into rehab, get them better with injections, medications, a variety of other factors, and look and see if they get better with non-fusion technology, because we do understand a lot more about degenerative disease than we did 10 and 20 years ago. The staff at the Center for Spine Orthopedics are honored to help patients from across the globe and to give evaluations and to help you make the right decision at the right phase of their injury or disease, and try to give them the most clinical outcome. Thank you very much.